Ben Chaffee, and I'm the director of our program in global oral health at the California San Francisco School of Dentistry. Thank you for taking time out of your day to join us today, whether you're making this part of your morning, your afternoon, or your evening. I hope you'll enjoy the programming. We have an outstanding lineup of speakers ready to share their insight. And it's hard to believe this marks our 10th annual Global Oral Health, although since we've held one of these symposium. In 2020, unfortunately, we had to cancel our event because it's set to take place in the early days of the pandemic. Now, thanks to our newfound familiarity and comfort using this teleconferencing technology, we can offer this event to many more people, a much broader audience than ever could have joined us in person in San Francisco. And I hear the 2019 symposium was pretty good. It was excellent, but I missed it. My son was born scheduled just 2 days before that symposium, and so I was in the hospital. I missed some great talks and a killer reception. Of course, my daughter decided she would also show up ahead of schedule, all 2 days before the symposium was scheduled. In the interest of keeping this event moving, and at least in part to help me get back to the hospital to pick up mom and baby and bring them home, let's get this event going. A couple of housekeeping tips regarding the Zoom platform. This event is being recorded, so for anyone who's registered to join us, we'll be posting a recording publicly available after the event. You'll see that there's a few features across the bottom of your screen that you can use to communicate with the organizers or the panelists. If you're having technical problems, if you can't hear us, if something just doesn't seem right, go ahead and use the chat feature. You can also provide questions to our panelists. After each of our sets of presentations, we'll hear about 4 presentations in a row, and then we'll have a moderated question and answer session. Send in your questions using that feature, and we'll respond to that during the raise hand feature. I actually don't know what we're going to do with it. My recommendation is not to use that. Look to your chat right now. You'll see that there is a link, or will be a link soon, to the program for the day. So if you can follow that, you'll be able to keep track of what we're planning to do. Some good news, we have some free continuing dental education units available for all attendees. We'll give you that link towards the end of the symposium. I don't have a reception to keep your attention, but at least I have some continuing education units for you to stick around to get. Keep in mind that those are may not be recognized in your country. They're dental continuing education units here in the United States. We don't have medical education units available, but hey, they're free. I do recommend, however, please only request them if you need them. We do incur a small charge for each certificate we issue, but by all means, please ask for them. They're not available, however, if you're watching this as part of the recording. That's one of the perks of joining us live. Some of our speakers, their talks have been pre-recorded because otherwise they'd be joining us at 2 or 3 in the morning. So if you are having trouble with the audio or visual or the internet connectivity, we're also going to give you a link so that you can watch those talks synchronously on YouTube, so that while we're broadcasting them, you can watch a cleaner stream on your own computer. And so with that, I'm actually going to turn it over to our first recorded talk. And this comes from the Dean of the UCSF School, Dr. Michael Reddy.
Greetings. Welcome to the 10th Annual Global Oral Health Symposium. As Dean of the UCSF School of Dentistry, I am honored to welcome you to this event. For a decade, this symposium has drawn world-renowned speakers and supported vital research projects in public health, epidemiology, basic science, in the realm of global oral health. This year's theme is unlike any other. You'll gain valuable insights from leaders across the globe on how their dental universities have adapted this past year during the COVID-19 pandemic. They'll share details on how their universities are continuing their missions in education, research, and patient care during this unprecedented time. You'll also learn about trailblazing global discoveries in clinical dentistry and public health. This year has taught us that the ultimate value of research is finding new ways to address the problems that plague humanity across the globe. Challenges like the COVID-19 pandemic call for creativity, collaboration, and commitment of healthcare leaders, researchers, and scientists. Each of you plays a vital role in this work. I want to thank Dr. Ben Chafee for leading our Global Oral Health Initiative at UCSF and for organizing the symposium for us today. Dr. Chafee never disappoints in his ability to consistently gather change makers from all corners of the world to share their work and inspire us. This year, we are honored to have speakers from Australia, Wales, Kenya, and Tanzania, in addition to UCSF. Let today's speakers inspire, energize, and propel you in your efforts toward achieving positive change in global oral health. Your work has never been more important. Again, thank you, Dr. Chafee, and thank you all for attending.
If I'm not mistaken, I think we may actually have Dr. Reddy live right here.
Sorry. Hey, Ben, it's great to be here. Thanks. I'm going to pop in and out throughout the day. I'm excited about the program. Thanks for having us.
Yeah, thank you so much. I'm glad you could be here. And for those of you who missed the audio feed, if you want to check out Dr. Reddy's presentation, the link to see it on YouTube is in the chat. And with that, why don't we get this event moving? We're right on schedule, 10 past the hour. And we're going to have our introductions rather brief. In fact, bios of all of our speakers are in the program. You could place that in the chat one more time. Everyone can see presentations and bios of our speakers. And our first speaker, we're very happy to welcome Dr. Nicola Innis from Cardiff University. She was set to join us at the 2020 Global Oral Health Symposium. And I'm so glad she was willing to come back and see us for this year. So with that, Nicola, please take it away. I think we have you on mute.
Thank you. Classic mistake. Good morning, afternoon, and evening, everyone. It's an absolute honor to be here with you today and to be asked by Ben to come and talk at the Global Oral Health Symposium. It was unfortunate that I wasn't able to make it over in person last year, but I'm very pleased to be here. And we've got such a packed schedule that I'm just going to jump right in and start talking about how we navigated the COVID-19 pandemic so far at Cardiff Dental School, where I'm the head of school. And I have to admit to you that I only took over the role as head of school here in the middle of the summer. So I missed part of the pandemic, but I've managed to hit a good bit of it. So I will share our experiences. This is a Gantt chart that just shows a little bit about how we navigated the pandemic for our undergraduate students. And this is what I'm going to focus on today. So this particular aspect of teaching, especially clinical work for our undergraduates, was the most challenging. We had moved all our teaching online from about the 23rd of March, both synchronous and asynchronous teaching, and we continue with that. You can see here on the chart that we started that and it goes on. What we had in Cardiff was an urgent dental centre in the hospital, which was treating patients. And that wasn't common across the UK. In the UK, dentistry completely shut down in most places, with only a very few places open up. And they weren't all dental schools and dental hospitals. Some of them were community outreach centres that were continued to be safer settings. And some of them were different urgent care centres that were set up in places. So we were really fortunate to have the dental hospital here. And I think that is one of the key things that have managed to help us over and above many of my heads of school colleagues in the UK who have really struggled to get their clinical students the clinical experience they need, especially in final year, to graduate next year. So that urgent dental care gave us a lot of information that we needed to inform getting our students back. What we're looking at on this slide is the hospital service and what happened there. So we had the urgent care only, the gradual build-up of the other clinical services as they started, and then the synchronous and asynchronous teaching with our school, the exams with our school non-clinical teaching and assessment, and our clinical teaching, which really only began in September with PPE and training for all the students, face fitting of masks, hoods, everything that we needed to get those students organised, and then clinics and patients and operative technique skills opening up once that was secured. We have undergraduate clinics running, but we know that our students have missed such a huge amount of clinical experience that we've actually increased the extra clinics that we have. We're running early mornings and we're running some weekend clinics in some of the centres to allow them extra time to catch up. And that's hugely advantageous for our population around Wales here in the UK, because the backlog, as you will all know, the need for oral health care is huge at the moment because of the shutdown of services and the limited ability to carry things out. We have two separate things that helped us, and one of them was the PCR asymptomatic testing that Cardiff University brought in on their own using researchers and laboratories within the university itself. So we brought two locus asymptomatic testing in round about September and made it available for all our staff and students. And they very much availed themselves of that. What that allowed us to do was have some confidence in taking our students from a very unknown position because of the lag time, the latent period for COVID-19 between being infected and being symptomatic, and finding out which students were asymptomatic positives and which staff, and immediately taking them out of the clinical situation. I can hand on heart and happily say that we did not have one transmission event through any of our clinical activities in the school. The transmission events that we did have were all related to social activities. So it was students sharing a house with somebody or with each other when one of them had tested positive, students who were sharing transport, which we eventually had to stop, and the same with staff. And what you can see at the bottom here is the first peak that we had in the UK, the second peak round about September, October, and then the big, much bigger third peak that we had. But what you can also see is that alongside those peaks in COVID-19, we managed to keep our services and our teaching, our clinical teaching and other teaching going. So I've got a few slides just to put some flesh on the bones of that. We carried out a big systematic review that you can all have a look at if you want, that helped to inform our sense of safety around about what we were doing. But we were very cognizant that that systematic review didn't actually tell us about transmission. It told us a lot about where spray went in the clinical surgery, but it didn't tell us about transmission of disease. There were no papers that talked about transmission in the dental team that we could find of any quality to do with viruses, especially respiratory viruses. We know that the virus settles down very quickly in a setting, but we in the UK have a lag time after any AGP of 15 minutes. And that, of course, has reduced our throughput of patients. But we have looked at our log reductions in viral load and whatnot roundabout, informed by the evidence, and are quite content that really what we're doing is safe. And as I say, we've had no transmission. So we looked at the worst case scenario and worked on that. And I'm just going to show you this, the Pcr Testing Service in the news that was set up, and it really gave us a lot of confidence in bringing patients in because patients were reluctant to come. We also have an oral microbiologist in our school, Dr. Melanie Wilson, who is a fabulous individual and went through all of the evidence to do with air scrubbing and air cleaning very, very early on in the pandemic. And as a result of her assiduous work, we bought HEPA filters and put them into the surgeries. And you can see 3 of them in one of our student clinics here. So there's one here, and one here. And what you can also see is that the windows are open around about. Despite the cold, bad UK weather, we've still been keeping all the windows open because we know that ventilation is a key. We've also got social distancing and PPE in our Optech labs, and we're following the Welsh Government definitions of contact in order to take students out when we felt that there was a need. So if they'd any evidence of the possibility of a transmission, so if they'd come into what we thought was a contact. The Welsh track, trace and protect system, which was actually very, very good and superior to some of the other nations, I should tactfully say, in the UK. And it allowed us to put our students into isolation as and when we needed. So you can see the number of students that we had to self-isolate because of risk of disease and because of contact or a positive test here. And actually, if you had the time to look at it, you would see that it mirrors here very, very closely. But it did give us more confidence in what we were doing. So we need our dentists, we need to get our graduates out. We are really struck by the sense from our regulator, the General Dental Council, of being wary about not sending our students out till we're absolutely convinced they have enough experience to go and are at the level they should be at. So I think we're really getting there in Cardiff. This is how we've managed the clinical teaching. And I just wanted to take this opportunity to say an absolutely massive thank you to my staff at Cardiff Dental School who have gone over and above repeatedly. And thank you all for listening.
Well, thank you for that fantastic presentation. And Wales during the pandemic. Our first series of talks, I should have said at the beginning, all relate to how different schools, dental schools and universities have adapted to the COVID-19 pandemic. And so our next presentation will be from Dr. Regina Mutave, Dean at the University of Nairobi of the School of Sciences. And just a reminder, any questions, comments for our speakers, please use the Q&A feature, and we'll get to all those comments in a discussion section after our first 4 talks. Dr. Mutave.
Thank you, Benjamin, and good evening, good morning, good afternoon, and welcome to this today's presentation. I'm really excited to be sharing with you the journey of the University of Nairobi, and basically I'll be quickly covering how the University of Nairobi School of Dental Sciences managed to really package itself and get back to clinical teaching. So I'm sharing the experience of the University of Nairobi. And yes, COVID-19 checked in Kenya, and the first case was reported in March, on March 12th, 2020. As a result, of course, the reaction was that all face-to-face teaching was suspended with effect from March 16th by the University of Nairobi, and that included clinical teaching. So we closed all our clinics on that date. The School of Dental Sciences, was affected quite a lot. The situation in Kenya today is that so far, the latest data for April 29, 2021, cumulative cases is 158,821 with 2,707 deaths. Among these were 3 dentists. And of course, I would want to share the bit of the data of the other thing that will be interesting, that in Kenya today, the vaccination is progressing a bit very slowly. Only 824 persons are being vaccinated out of the first priority group. We hope as we go forward, this will improve. So the building of the dental school, which is the dental school is housed in its own campus, remained closed for at least 2 months with not much activity. Of course, the environment then, there was generalized fear, apprehension, and a lot of anxiety, with nobody trusting the other one to come to interact with. And for that reason, I, as dean, began visiting the school as a lone soul, and soon mobilized the managers. We sat down and began thinking what to do. I mean, we knew the transmission mode was really challenging. There was a severe shortage of PPEs across the globe. Whatever could be found was dedicated for the COVID-19 measures. And so we began to look at our basic infection and prevention protocols and did a very technical retreat to assess the situation. And out of our intense assessment of the situation, we began to see some little lights somewhere where we could penetrate, that we already had an infection prevention control measure in place before COVID struck. And so this list here was things that we already were doing. We were using gloves, 3-ply surgical face mask, and sterilizing our instruments. Our cubicles were semi-partitioned, and we had implemented a cashless payment system. So we thought those were good ones. There were also other things that we did in the clinical area, having hand sanitizer dispensers and hand washing by the chair side, access to high volume suction, although some of them were not working. And we had a changing room, which was in the operating theater. This would prove to be interesting additions when we started looking at adapting to the practice in COVID-19. So we looked at what gaps we needed to address. And there were certain things, of course, we had never before used N95 masks. We used goggles for some procedures, and we did not have any hand wash stations outside the building or hand sanitizer points outside the treatment cubicles. So this needed to change. We needed to bring on board more changing rooms because all staff and students were now going to require them. And we even had to improvise and have a laundry on site and try and tent for screening. And of course, at that particular time, we needed to screen patients for temperature. There were certain other advantages that our school provided. The fact that the campus sits alone with controlled access points, the fact that the building only has a few access points that we could manage, and the parking was large, open, and we could modify one or two things, and there were spaces that were available that we could modify. And our clinical areas were designed with very wide windows, which we could manage to open and allow air circulation. So these are things that we began to look at and appreciate. So for a start, we have our gate, and we managed to have our temperature screening at that point. And we had to put a triage tent just outside in the parking. And of course, we modified this building. We had hand wash in this area and directed traffic to make sure that this was only entry and that was exit. Of course, Benjamin knows that the dean sits up there, and I could watch and monitor what is happening outside. So there was also the issue of the real challenge with PPEs. The cost was a problem. So although we had received the Ministry of Health recommendations, we had to think outside the box. And I must say that our staff actually did mobilize funds. Industry partners did mobilize funds. Our alumni mobilized funds, and were able to buy a couple of personal protective equipment. And while doing it, the faculty went through a lot of training for online teaching. And the lectures were delivered to students as they awaited readiness for clinical teaching. And so as we prepared to reopen, all staff, regardless of their grade, were retrained on the new protocols before they could assume their positions again. And we had online sessions, there were hands-on sessions in small groups, and PPEs were actually sourced amid the challenges. So after all the preparations, we were back to clinical teaching in August 2020. And this time we adopted 400 dentistry, which became mandatory for all clinical areas. And we also had to shorten our clinical hours so that we reduce the period of exposure. Of course, all the cases that required admission to for our inpatient care had to get a COVID-19 negative certificate before we did that. And what I must say is that we so far recorded one case of transmission of COVID from a patient to one of our postgraduate students, and that happened in February this year. Otherwise, between August when we opened and February, we did not have a single case, and we hope that we'll not have another one. We managed to do all that when we actually ready for graduation in December, and we managed to inject fresh 25 undergraduates, graduates, and another 4 postgraduates into the market. And I think we did a follow-up, and got some bit of uplifting feedback from our graduates that out of the 25 that graduated, 21 of them responded, and a whole 20 out of the 21 felt that we gave them good competencies to manage patients in the dental setting during COVID-19 pandemic, while a smaller number, 16, indicated that they received either good to very good training to prepare them to work in a dental setting during COVID-19 pandemic. There were issues, of course, there are issues. Most of their current stations are yet to really stabilize with provision of adequate, good quality PPEs. Of course, for dentistry, then, what does it mean having it gone through that? We still have a lot of unanswered, questions. The mode of transmission is still very, very tricky. There are lots of questions around it, and even with the disinfection protocols, we're still struggling with what works, what doesn't work. And I think more research is bringing out a little more information at a time. And of course, with the rational use of PPEs, how much is adequate to protect both patients and operators? And knowing that even at the moment, we continue to train with a much exaggerated cost, either for training or for the dental services. The questions are who bears the additional cost, either for the PPEs, who also bears those additional costs. And COVID-19 as it is has put a lot of limit even to the public service, dental services. How will stakeholders be cushioned, especially the marginalized groups? So we continue to really look at these questions and battle with them to find reasonable answers. I guess a lot more research needs to be done, and I want to thank you very much for listening. And I look forward to hearing the research part of this presentation. Thank you.
Thank you very much, Dr. Mutabe. That was great. I really like that you added some questions at the end that I hope we'll be able to return to during our panel session. As a reminder, anyone else who comes up with questions along the way, by all means, enter them in the box, and we'll address those during our panel. Now we'll turn to hear a little bit about our own university here at UCSF from our Associate Dean for Education, Dr. Sarah Hughes.
Thank you, Dr. Chaffee, and welcome everybody. It's an honor to be here today. I guess I should start just by saying that this is from our stock university templates. And so my first image actually isn't COVID-19 PPE compliant. And that's certainly something that we have to address to get some new stock slides done. For anyone that doesn't know us, I thought I'd start with a bit of an overview about UCSF. UCSF is exclusively a health-based university. We have a school of medicine, nursing, pharmacy, dentistry, and physical therapy. This is really our USP and what we're known for. But we're also a very large and dedicated education institution. And I think in all that we do, this can sometimes get overlooked. So I'm delighted to have the opportunity today to talk to you about all things education. During my brief presentation, I thought I'd share with you sort of our COVID-19 education impact timeline for California and San Francisco, and dive slightly into sort of 5 vignettes out of that and the influence that they've had and how we've adjusted to COVID-19, and then draw out my summary. So where we begin, February the 3rd in San Francisco was really the starting point for us, and we opened our Clinical Emergency Operations Center. We were hearing, global pandemic, deaths, rises, and so really this was the hub of how we were going to manage our clinical operations. But very soon, by March the 7th, we realized that COVID-19 was going to have significant and long-lasting effects on education as well. And we opened the education branch of our Emergency Operations Center. We'll talk a bit more about that in my first vignette in a moment. By March the 10th, we had in place daily briefings with the leadership team, both within the School of Dentistry and across UCSF at large. 7 days a week, including weekends. We held weekly town halls. We had themes of clinical practice and operations, research and scientific discovery in our labs, and obviously, from my perspective, education. On March the 13th, as things were becoming a little bit more concerning, we decided that we would extend the student quarter break. Now, the main reason for that was to give us time to get some good quality remote learning resources ready. And I think that was a good starting point, because very soon after that, on March the 15th, our mayor, London Breed, and the San Francisco Department of Public Health issued a shelter-at-home place and order. And then we began the process of seeking exemption for our clinical students to be able to come into clinics and, where necessary, travel on public transport to do so. We remained open for our patients and patients that had no access to care. And if you're not familiar with San Francisco, it has a large homeless community, and other dental practices were rapidly closing. By March the 17th, our students, and particularly concerning for our class of 2020, heard that all clinical licensing exams across the state of California had been suspended. By March the 30th, 2020, our accrediting body, the Commission on Dental Education, CODA, issued guidance to US dental schools about what we must do in terms of making sure that we remain compliant with our accreditation standards. And I'll look a little bit more at that in vignette 2. And by April the 6th, we were ready to go with all classes remote, having extended quarter break. And we launched a new clinical professional learning series for our students, which I'll tell you a little bit more about in a moment. By April the 9th, realizing the sort of social impacts of COVID-19 on students, we opened and launched a grant scheme to support students with housing, moving into temporary housing, food insecurity, and students did not have to worry about paying back these loans and these grants. On April the 17th, we formed a California-wide dental school coalition, and we began to lobby the Department of Consumer Affairs. And I'll talk a little bit more about that in the third vignette in a moment. April the 21st, for our should be graduating class, we decided to do one-to-one meetings and write individual evaluation plans for each student to see what was necessary for them to graduate on time. And that's a cohort of 116 students. On May the 18th, our evaluation strategy that we wrote for every student was approved by campus, and we were allowed to bring students for limited care, for limited evaluation, for simulated evaluations and other things back onto campus. And that was pretty effective, and I'm delighted to report that we were able, under exceptional circumstances, to graduate the class of 2022 on time on June the 30th. Shortly afterwards, I'll tell you a little bit more about this in a second, we opened and developed a new group practice model of education. August 5th, we hosted a new inaugural simulated licensure exam. And on September the 23rd, we launched a new dental labs at home project, which again forms our final vignette. So from the first vignette that I want to talk about, it's really the beginning, what happened? Well, we have to say that COVID-19 was a disruptor unlike anything that we've ever seen before. And I think the most used word now is unprecedented. We knew we were going to have to work from home, but we really didn't understand what learning from home might look like. We had to support faculty to think, therefore, very differently. We had to transition things like our extensive gross anatomy training so that it was conducted by faculty in isolation and video cammed to students remotely at home. And that we were leading VR vivisections done through remote technologies, something that we had not done before. We had to completely write and publish a brand new didactic schedule. We had to think about our preclinical and simulation lab and learning environment. We had a traditional attendance approach that needed out-of-the-box thinking and a radical reform if we were really going to teach it differently. We had to also work out how to build a virtual community and support our students at distance by social interaction, by doctor's hours, by online counselling, through town halls and other events. And importantly, we knew that transitioning our education during a pandemic was a whole team event, that through every member of staff, faculty and administration would only be successful. As you've heard, obviously part of everybody's strategy and our reliance on technology enhanced learning has significantly increased. And for us, one of the significant considerations was how we would continue to progress students at pace through the curriculum. And this became one of the most significant elements of our accrediting body, coders, reporting requirements. They wanted to know how schools were going to tackle examination integrity. So for us, that looked like proctoring of our examinations. We were already using examination software to which we added remote AI proctoring technology. This was a huge project involving our legal, privacy, and IT security teams. We also had to work with the Academic Senate on amending our examinations policies and procedures to bring in this new technology and approach. We introduced Otter software, which is running in the background today, as a mean of transcribing all of our sessions to support our students with accommodations and to ensure that we remained compliant with the US Disabilities Act. We designed and launched a new clinical professional series to build, strengthen, and ultimately test the clinical reasoning of our students. We know that the tenets of clinical reasoning are built on the skills of analysis, interpretation, explanation, self-regulation, critical reflection, and problem solving. So the CPS was a new series of workshops, activities, vignettes, case studies, discussion forums, and clinical scenarios for our students to work through with faculty remotely. We had to cancel our community-based clinical learning program, and working with our site director in California, we wrote and published a new preparation for employment and serving the hard to reach and easy to ignore communities series that will now be a permanent feature of our third-year curriculum. We were obviously conscious about the new curriculum and pace of learning that we were exposing our students to by remote means. And we didn't know what the effects of Zoom fatigue would have. So we ran daily Qualtrics evaluations. Have we got the pace right? Is it too slow, too quick? Are you spending too long doing this? Are you keeping up? Are you struggling? And we made daily changes and iterations to our schedule in response to this. Vignette 3 is about lobbying. And as I said previously, we came together, all of the dental schools across California, the 6 dental schools, to form the California Dental School Coalition. And our intent was for lobbying to change the Western Regional National Examination Board requirement to hold a live patient licensure exam. As you saw in my timeline, our lobbying was thankfully successful. And in August 2020, we hosted the inaugural simulated examination, which is what enabled our graduates in the class of 2020 to gain their clinical license and join the profession. But that meant we had to quickly prepare our students for a brand new type of exam. And I'm also delighted to say that they all passed. And we also launched a group practice model. And let me tell you a little bit more about that. We've been thinking about implementing a group practice model of clinical education for some time, but we had to ask ourselves, is this the right thing to do during a pandemic? And we did for 2 key reasons. People were responsive to change, and we wanted to ensure the safety of our patients and community at large. Our patient demographics skew towards an older and sicker Medicaid population. And the recurrent question we were asked is dentistry safe? So we needed to find a way of reassuring everyone, and group practices seemed a positive start, along with new permanent barriers to our cubicles on the clinic, new environmental controls, revised health and safety policies, COVID testing for patients and our community at large, and a new video about safety on our clinic. We appointed 7 full-time group practice leaders. Structurally, each group practice is assigned an equitable number of clinical cubicles, and each group practice is operational and treating patients every clinic session throughout the week. The group practices and our faculty coverage schedule were designed to ensure that either the group practice or our assistant group practice leaders are present every clinical session. And this has allowed for cohesive, continuous oversight of our students and patients in each of our groups. Our group practice model has allowed us to improve our new patient intake process with quicker, better managed and data-driven patient distribution and allocation. So the good news is that on October the 1st, 2020, we were approved by UCSF to be 100% at clinical capacity, which would not otherwise have happened without group practice model. It was the first group of students on practice 100% of the time. So I end this vignette by saying, yes, it was a risk to complete such a huge structural change during a pandemic, but it was a well thought out risk, and we believed it has paid off. And in my final vignette, I want to just talk briefly about our Labs at Home project. In the vignette so far, I've talked about influences upon our existing student body, but we were also preparing for new intakes of students in June and September of 2020. We had campus approval for 50% capacity in our preclinical laboratory, and we knew we had to supplement their learning in some way for them to be successful. Thinking through some of the earlier theories of our education thought leaders, Vygotsky, Froebel, Piaget, we recognized that this meant finding ways of developing your hand skills outside of the confines of the preclinical simulated learning environment. Our answer to this and our approach was portable, electric, micromotors and vacuums that allowed students to practice their hand skills at home. We also updated our in-lab recording equipment so that 50% of our students who were scheduled to work at home could follow the real-time instruction that was taking place in the laboratory. We are currently collating data and student feedback on our pilot project that will help us and refine, improve this new way of learning. And faculty have asked that it remain a permanent feature of our preclinical learning program. So, in summary, we have dealt with enormous challenges, but together we've overcome them. And in real terms, we've seen some of the most significant and long-lasting changes to dental education that have been seen for a very long time. Now, many of these changes, as I've described, have actually been positive and will be long-standing. But with each and every day that continues, we must remember and continue to think about the side effects that affects our students at large, such as housing shortages, access to food security. And we're not all the way through this pandemic yet. And so each and every day, we will continue to learn more, grow more, and respond in terms of developing our curriculum. Thank you very much for your time. Again, like my colleagues, I'm very happy to answer any questions that you have, so please reach out and contact me directly. Thank you.
That was fantastic. Thanks so much, Dr. Hughes. I really like those animations. That was a nice touch. That was fabulous. We have one last presentation before our panel. Thank you for everyone who's entering their questions in the Q&A function. The next presentation, Dr. Pauline Ford, who is the head of school at University in Brisbane, Australia. But because it's now very early hours of the morning Friday, Australia, the presentation is pre-recorded. Because sometimes there are technical difficulties. If you go to the chat, you can find a link to her presentation on YouTube if you want to watch that on your own time in parallel on your computer. And we'll also play it live right here through the Zoom channel. And here we go.
Hello, I'm Pauline Ford, and I'm talking to you today from the University of Queensland School of Dentistry in Brisbane, Queensland, Australia. I've been the head of the School of Dentistry for 5 years, including last year, and I've recently moved to an Associate Dean role. Thanks so much for the opportunity to contribute to your symposium by sharing some of our reflections on our journey through 2020. So here at the School of Dentistry, we're located on a hospital campus. We moved to a beautiful new building in 2015. We've got a fairly large dental service facility which accommodates our students' clinical placements. We're a fairly small school. We have 55 staff, cohort of around 400 Bachelor of Dental Science honours students, 30 Doctor of Clinical Dentistry or Specialty Training Program students, and 30 PhD or MPhil students. Current status of COVID-19 here in Australia is that we're now producing our vaccine locally, the AstraZeneca version, and the vaccination rollout has commenced with the first priority populations receiving vaccinations. Our international borders remain shut and there is little political will to change that in the near future. We're very fortunate that currently our restrictions are quite minimal. Currently there are 149 COVID cases, all of which were acquired overseas. Over the course of the pandemic, there have been around 30,000 cases and a death toll of 909. That's in the context of a total population of 25.7 million people. We have had 2 waves here in Australia, the first in March, April, and then the second larger one, July, August, which was focused primarily on the state of Victoria. In Australia, the Australian Health Protection Principal Committee is the key decision-making committee for health emergencies in Australia. It's comprised of all state and territory chief health officers and is chaired by the Australian Chief Medical Officer. Commencing on the 29th of January, the AHPPC provided regular COVID-19 guidance to our political leaders, health services, universities, businesses, and the general public. And that's resulted in a generally cohesive and effective national response. The Australian Dental Association developed additional infection control precautions to manage risks in dental practice, as well as manage practices for patients at risk of COVID-19 and for those diagnosed with COVID-19 and who needed urgent care. These guidelines outlining 5 levels of restrictions were endorsed by the AHPPC. The AHPPC recognised that if access to dental care ceased entirely, this would place a burden on medical primary care and emergency services at a time where that just couldn't be afforded. Level 3 restrictions were applied from the 27th of March, and that meant that no treatment could be provided that produced aerosols. This went to level 2 from the 26th of April, a small increase in the range of treatments that were allowed, still minimising aerosols. During this time, there was a tension between maintaining clinical placements and a rising anxiety of the health services and of students. An added complexity was the shortage of PPE supplies and the uncertainty regarding the type of PPE necessary. From the 7th of May 2020, Australia has been operating at level 1 restrictions, which means that we've basically been able to provide all types of dental care except for non-urgent care for suspected or confirmed COVID-19 cases. So what does all that mean for the School of Dentistry here at UQ? So like all dental schools, it was a tricky year. We started the year by listening closely to any and all advice and information that was available, while simultaneously undergoing scenario planning. During the week of 16th of March, the University of Queensland decided to pause teaching for a week. And that was to provide the time, not much time, but some time for academic staff to rapidly convert all of their materials to online. Around about that time, our overseas students, particularly those from Singapore and Canada, were under pressure from their families and home governments to return home, and many of them did. Soon after, our clinical placements ceased, except for our rural clinics, and I will explain a little bit about that in a moment. Closely followed by a directive for all staff to work from home, except for those staff involved in continuing critical research activities. Our regulator, the Australian Dental Council, required fortnightly reporting during this rapidly changing period, and that was to ensure that the changes that we were making were in line with their expectations around what was required of students at the end of the program. Over time, as the first wave subsided, and in Queensland we were relatively protected from the second wave, we've moved back to resume clinical placements and on-campus activities, but we realise that we're much more fortunate than many others. So our rural dental clinics are operated by the School of Dentistry, and they are in 2 very small towns which are west of Brisbane. So they have small populations, not great access to services or dental care otherwise. And they service a community that has a large population of Aboriginal and Torres Strait Islanders. And this particular community is very susceptible to COVID-19 impacts. And so it was particularly important that we considered carefully our ongoing activities in those clinics. So we consulted very closely with the community and peak body, and the advice was to continue with our clinics because they were providing an important emergency service for the community and preventing them presenting to hospitals. There was no confirmed cases in that area, And so it was decided that with very high level of caution, so minimising face-to-face contact as much as possible, isolating staff and students arriving in the community, that we should indeed continue our services and placements. And we operated right through the pandemic with no break, and we're the only clinical placement site in Australia for dentistry that was able to do so, and we're very proud of that. So our students who were not involved in clinical placements were having a very challenging time adapting to online learning. So one of the initiatives that we undertook was to send them a care pack with some very simple materials that enabled students to get involved in a weekly competition. So you can see that some of our talented students here did some really great work in the drawing challenge, the sewing challenge, and the wax tooth carving challenge. My personal favourite, though, was the baking challenge. Where are we now? So at the end of last year, all of our students graduated as planned, and students in their final 2 years of study were approved to return to Australia if they were overseas. Of course, they have quite an altered plan of study to catch up on what they've missed. We still have around 50 students in earlier years who are at risk of progressing normally through the program if they're unable to return very soon. Student wellbeing through last year and into this year is a concern. Some of our students haven't been able to see their families and homes since early last year, and everyone's struggled with the isolation of online learning. I'm really very proud of our staff who have embraced blended learning and assessment approaches, engaging with new technologies, learning new ways of doing things, and reflecting on old practices. Our students have told us that they want the best of both worlds for future learning, face-to-face and on campus when it adds value, and online where it makes sense and gives flexibility. We've concluded that the lecture isn't dead, but we have certainly reimagined it. The University of Queensland has provided extensive support and including financial support to our students who have been at risk or in very challenging situations over the last year. And I think that's something that we really have to keep in mind, is the impact on student wellbeing. So today is the 26th of March, 2021. At the beginning of my presentation, I indicated to you that we had minimal COVID-19 restrictions. However, in the last couple of hours, a new community transmission of unidentified origin has been detected. Now, we are currently awaiting what the outcome of that will be, but I guess that's the lesson of 2020 and 2021, is that we need to remain open to change. We're not through this yet. We've learned lessons. I think that will see us through the other side. And I'd just like to congratulate everyone who has managed to keep their head above water through a very challenging period. Thanks again for the opportunity to speak with you today. It's been a real privilege.
Well, I hope everyone found that to be a really informative set of presentations. Dr. Ford sends her regrets that she can't, but I really enjoyed her presentation. What stood out to me was those really creative and talented works of art from their students, including the edible ones. Now we're going to spend some time to go through question and answers with all four of our speakers from whom we just heard. Answer box, please, in there. I know we have even one more answer, so we'll be sure to address all of those. And to lead this session will be Dr. Yvonne Capilla, who is a professor of periodontology right here at UCSF. So I'll turn it over to you.
Thank you, Ben, and thank you all to our panelists this morning, afternoon, evening. It's been wonderful learning about your journeys at your schools and all the creative things that you have initiated for the COVID pandemic. We have some great questions from our audience, and I will start with the first question, and it's open to all the panelists. The first question is for all the panelists to consider what would be the role of improving oral health as an upstream prevention for COVID-19? Any thoughts on that question? I'll repeat it, or Dr. Hughes. Thank you. Thank you.
I think audio might have cut out a little bit. I think the question, yeah, go ahead again.
Okay, I'll repeat the question. What is the role of improving oral health as an upstream prevention for COVID-19? So how can we use oral health as a preventative perhaps for COVID-19? Maybe what we know about the biology of the oral cavity in terms of its receptors and so forth for COVID-19. So how can we use oral health as a preventative?
Well, thank you. Thank you very much. Quite a tricky question, really. And I must say, at the start of the pandemic in Kenya, I do not think dentists or trained oral health practitioners thought they had a place in the management prevention of COVID-19. However, if we think carefully, there's a lot happening about saliva diagnostics and other methods that can be used to pick be able to assist with the diagnosis for COVID-19. And I think there's room for further engagement of oral health practitioners and researchers to enhance the picking of early cases of COVID-19, and of course control the pandemic. And also, although in Kenya, dentists may not have participated very heavily in COVID-19 management, probably maybe because we haven't had a very severe, pandemic curve. I believe there are places where dentists have played key roles in just attending and doing emergency response where the rest of the healthcare workers are overwhelmed. But I see a bigger role in research where which involves the oral cavity, the diagnostics, and looking out for signs and symptoms that can, quickly give an indication that we can pick out COVID-19 cases much earlier as a profession. Thank you.
Thank you, Dr. Mutavi. Absolutely. I think we at Dentistry are absolutely at a wonderful position to be able to use prevention to our advantage. There's a few other questions in the Q&A. The next question is, do we have an idea regarding the impact of COVID-19 on the outcomes in terms of learning achievements for our learners? Any idea?
I wonder if I could add something to Dr. Mutavi's
Absolutely.
answer just to the last question. So I think it is difficult to think of an upstream response that we could immediately do given the nature of COVID-19. But I think one of the things that we really need to embrace as a profession is understanding the transmission that occurs during dental treatments so that we don't end up in a situation very similar to the one we have in the UK, which could easily be across other countries and could be much worse if the transmissibility of the virus was any higher. So we're very lucky that the rate of COVID-19 transmission is as low as it is, because if it was much higher, we'd be in a different position. And we know that there's very little viral RNA detected in saliva after we've used AGPs, so aerosol generating procedures, around a dental surgery. It's simply because we know that the amount of saliva that spreads is very low. And we've got some vague ideas about the amount of RNA, viral RNA in that saliva. So we can do some guesses as to what might happen. But we really have to take this pandemic as a warning as to what might happen and what would happen if we had increased transmissibility and we needed to carry out dentistry, because oral health is critical to patients' happiness and well-being. So I think it's fun. It's really, the onus is on the profession to investigate further the effects of PPE in mitigating the outcomes that we see, and really thinking about doing something that shows how safe we can be and maximizes that, because the PPE that we're wearing at the moment is really cumbersome. The fallow times that we have in the UK, and I think maybe in other countries, really reduces the throughput of patients. By understanding that and by understanding where our thresholds lie, when this happens again, we can be much better prepared. And I think it's to our credit in dentistry that we have the PPE standards we have. And I think that is being so fundamentally used to PPE in our day-to-day practice is part of the reason that each of us can say we had such low or zero transmissibility in the environments despite the risks. Thank you.
Thank you, Dr. Innis. Another wonderful response. I know we've also used pre-procedural rinsing in many places. That's another tool for armamentarium. So to repeat the other question, another question on the Q&A. So again, to all the panelists, regarding the impact of COVID-19 on the outcomes of learning achievement for our students, our learners, any thoughts on that question?
I'm happy to start. And I think if we're running a sort of true outcomes approach to our curriculum, then the impact is significant, because we're trying to place students at their own pace in the right environment, doing the right thing, irrelevant of the year or phasing. So a true individualized curriculum, and COVID-19 for sure makes that much more difficult. We certainly don't run a full outcomes based curriculum. But the one thing that I think I can say that we've all probably had to do, and we certainly have, is to really look very carefully at our milestones. What do we expect a learner at this stage to have done, completed? Where are they on that trajectory? And that's where our one-to-one meetings with 116 students was vital, to make sure that we really understood the individual trajectory of a colleague, from student doctor to safe beginner, and to make sure that we can map and monitor that pathway for them. So in terms of outcomes, there are certain areas that we've seen a decline in our data. For example, implants. If we take the sort of complex surgeries, we're going to see patient confidence has dropped, our rate is reducing. And why I spoke a little bit in my vignette about moving to a different model of education was to really focus in and address some of those things, because we have to be much more mindful of that data, and we have to be much more conscious of how we move our students around and make sure that they get the experience where it is afforded, so that we don't have cohorts of students where certain students are graduating with large data sets of certain abilities and treatment behind them, and other students haven't been afforded that benefit. So the answer to that, what I think is a very good question, is yes, we have to work much, much harder on the outcomes basis of an educational provision during COVID-19.
Yes, and if I may just add on to what Sarah is saying, I think probably the full impact of COVID-19 to dental training may be assessed a couple of years down the line, because it might be premature to really give a very thorough assessment. Most of the classes that were caught in between in 2020 had already had quite some normal, so to speak, learning, and they may have been at different stages, some very close to graduation and remaining just a few polishing up. And so probably the next few classes where as we note that there is reduced patient confidence, and as a result, that the students may get fewer case scenarios to deal with. And I think it would be a good thing to make an assessment of where we are, how has it impacted, how do we, you know, get back on course. At the moment, we're doing a lot of blended learning. We're still doing a lot of online teaching and a lot of clinical teaching, but definitely with the rate of COVID-19, there's definitely the population isn't ready to come right through unless they really have serious dental disease. A lot of people are willing to postpone what would be just routine dental care. So, and that's likely to have an impact itself. Thank you.
Thank you, Dr. Mutabe. We have a couple of other questions that I'm going to phrase together because I think they sort of all relate to the learners. One has to do with competency, and there's questions about the concern or assurances of how we really achieve competency for our students with these challenges. And then kind of a related question is the use of simulations and typodonts. So maybe the panelists can comment on these two related ideas.
Perhaps I can say something about the use of typodont and operative skills. Our regulator, the General Dental Council in the UK, have been very clear that they won't accept an alternative to clinical care for certain aspects of our patient care. So we're really required to deliver the same kind of experience in terms of upskilling students in operative techniques and the carpentry side of dentistry, if you like, before they see patients, and having those same gateways for skills. But we can't replace our clinical experience. So the experience of carrying out a certain number of fillings to reach a competency, and it's not that it's a numbers game, it's that that practical experience is expected to be there to build a picture. And we've taken a portfolio approach for our graduating students to try and build that full picture, because it's not about doing things a certain number of times, as everybody on the panel and everyone else that's listening will know. Some people pick up the skills much more quickly than others. So we're using a portfolio approach to show that the clinical skills that we have in our patients that take place outside of the mouth are at a certain level, and then it maybe requires less time with a real patient to reach that level of competency that we expect the new dentist, graduating dentist and safe beginner to have. So although it supplements it, we've got a very clear position from our regulating body that we can't replace it with that.
We just echo, we have the same from our regulators saying, you know, you can't substitute A with B. We've written 21 interruption of education reports confirming that we're not swapping A and doing B. And so really, you know, we are held to the same standards, and that means, you know, we have to work. I think my last answer sort of explored that we have to work so much harder to make sure that, you know, we can give our students the sort of curriculum they deserve and the exposure to, you know, treatments and cases that they need. And it's a challenge, as Regina said. It's a daily challenge.
So here's another.
Yeah, so I can assure you in Nairobi, the standards remain the same, and that's why we struggle to make sure that we can have adequate numbers of patients. Definitely the regulator, in fact, when we were resuming, the regulator was very categorical that we needed to demonstrate how we're going to meet the required competencies, and we're still at it. We as I said, we explore a lot of blended methods to ensure that there's learning outside the clinic, and so when there's an opportunity to learn in the clinic, it can be utilized to the maximum. And we just hope that we'll be able to have adequate clinical exposure, but there's no replacement for it. Thank you.
Thank you, all the panelists, for your answers to that. There's some other interesting questions which sort of come at from very different, I'm assuming, locations, because they sort of mirror very different scenarios. So one question asks about recent graduate job prospects. And then there's another question that talks about in India, coming from India, where they have huge numbers of infrastructure issues, and where providers are constantly becoming positive, and how do they deal with this wave of difficulty in potentially having to shut down and lockdowns coming in their country, in India. So sort of two very different locations experiencing moving on following maybe post-pandemic in areas where rates are lower and job prospects, and then in other countries where there's another huge wave coming in India, and they face real challenges of inability to address infrastructure problems, management policies, and so forth. So from really two different perspectives, any advice from the panelists?
Well, I'll
okay,
I'm not,
you go.
I'm not an expert in sort of the Indian healthcare provisional service, so I won't touch that one. But I think the job market is obviously very local, and it's very influenced locally. We know, I think, data from around the world shows that many of our graduates, even if they haven't sort of lived in the area where the dental school is, tend to stay and practice in that area. So that keeps, in essence, we don't see much mobilization of an immediate graduate. So that keeps the kind of job market as the job market was in that sense. But we will start to be seeing, obviously, there are influences on the job market, in all areas, different styles of practices, different ways of working that we need to be exposing our students to and preparing them for. And obviously that gets harder under current conditions. But from this sort of San Francisco perspective, the vast majority of our graduates head into residency, and that's sort of 65 to 85%. And those residencies are still needing residents, they're still needing, expert workers to be developing their skills. So, most our students, we're not at this point having specific sort of employment problems. And we've seen no change in numbers. I don't know if that's the same elsewhere, but like I say, the job market is so, I think, sort of locally dependent that it will vary country to country and region to region.
In the UK, our graduates, after their 5 years at dental school, go on to do a very structured year or more in practice, and then through hospitals if they want to go into specialist training. And we've worked very closely with the regulators to ensure that that pathway is still there, knowing that across the dental schools in the UK, not everyone is going to be able to graduate all of their dentists, their dental students, this year in summertime, that it's likely that there will be a few who haven't reached the standard or had the clinical experience that they need in order to progress. So that's meant that that pathway has had to change a bit. The job market outside of that, I mean, one example I can give you is that in Scotland, in the UK, the 3 dental schools there will not be graduating their students this year because of the lack of them being able to give enough clinical time to the students. That's completely related to the infrastructure of their buildings and the lack of ventilation within very old UK dental hospital buildings. That's meant that it's really put them in a very difficult position, and they're having to put a lot of building works in place to achieve a safe standard. But outside of that, I believe the market is a bit fluctuant in the UK. My understanding is that there is a higher level of retirement from practitioners who own practices, and yet there's still that huge need. So I think it's not really settled down in the UK at the moment. So it's a bit of a guess. And again, a bit like Sarah, I would be being very presumptuous if I was to try to answer the question about India, and my heart goes out to everybody there. But one thing I would say is, again, maybe as a dental profession, we should be able to get together a little bit to help the education side of India and share some of our resources that we've put such a massive effort into developing, even if it's just some of the online asynchronous learning materials.
Yeah, so thank you very much. And I think very much share with what my colleagues are saying, that job markets tend to be very, very much localized. As just like the UK, our Kenyan dentists will complete the course in 5 years, and they will do a mandatory 1 year of internship placement where they do work under close supervision, and they're based in the larger hospitals. And so all our students that graduated in December began this internship training in January. And we do not see any reason to think that there is going to be change in that at that particular level, because it is a government driven internship to ensure that people can qualify to practice. I think it is difficult to comment about the other universities. I know in Kenya, University of Nairobi is the only one who managed to graduate. So we only have one more university, and I think they struggled a lot to get to a place where they could be able to graduate their class. I think they're expected to do so anytime this year. And yeah, I think we still have a lot of workforce to produce for the country. So yes, we may not be talking about a glut yet, and we may not be talking about business shrinking, because dentistry in Kenya is young, and we still have very small numbers that need to be built up on to meet the needs of the country. Thank you.
Thank you, panelists. I think we have time for maybe one more very quick question, because we do want a short break. And there's several questions that have come up on prevention. And would this be a good time to maybe focus curriculum more on, say, upstream prevention, epidemiology, political advocacy, silver diamine fluoride? Sort of these topics have come up in the Q&A. Any thoughts on that?
I would say yes, of course. And my research expertise is mostly around cariology. And we have a number of low and non-aerosol generating procedures that we can use in the time of COVID. But we also have a great deal of minimal intervention techniques that once the disease has occurred, we should be using much more than the highly interventive ones that we have as a kind of quaternary prevention approach. And prevention and understanding the environment, political lobbying, and all these things are the absolute key. And dental students should be being trained in that. Absolutely, 100% is how the profession will progress.
Completely agree.
Yeah, I think that's the way to go, really. I think even as a country, we're in the middle of revising our policy, and I think we are thinking a lot prevention. And once you align policies, everything else, including the training curricula, will also have to align to prevention. It's long overdue, and I think it's coming. We must embrace it. Thank you.
Thank you. I think I'm going to turn it over to Ben for maybe guiding us to a quick break.
Yeah, thank you so much. Thank you for a really great discussion. Thank you to everybody in the audience who offered some questions. I was having some internet connectivity problems downstairs next to that big mouth mirror, so I moved up here where the internet's a little stronger, but the clock is also reminding me we should give everyone a little chance to stretch and get up out of their chairs. So let's take just a 5-minute break. We'll come back at 30 minutes past the hour. We're not done. We have 3 more presentations, research talks, and we'll follow the same format. We'll listen to those talks. We'll have a cute question and answer session. But for now, stretch your legs, and we'll see you again real soon. Be back 1/2 past the hour. All right, I hope everyone got a chance to change their position, grab a snack, and refocus for another set of fantastic talks. Thanks again for joining us. Our second session, we're going to shift gears a little bit. Instead of talking about the impact of COVID-19 on dental universities, we're actually going to share some cutting-edge research talks. And our first presenter is also the first presenter from our prior panel, Dr. Nicola Innis from Cardiff University. Now, instead of wearing her leadership and administrative hat, is actually going to talk about her own research interests in cariology. And so with that, I'll turn it over to you. Thank you.
Thank you again, Ben, and once again, thank you for the invitation to be here to talk about clinical trials in cariology. And I'm going to talk about a very short talk on a very long journey that I hope at the end expresses a sea change in a way that we have moved in research alongside the sea change that we see in cariology from the very invasive treatments that we used to have, where we drilled everything that looked even remotely like caries, and we had a prevention extension for prevention approach, to the approach that we have nowadays, where we understand that we can seal the biofilm in, that we can use prevention, that we can arrest lesions by removing the biofilm repeatedly using SDF and all these other things. So what I'm going to talk about is from a very simple randomized controlled trial that led us to undertake a very complex randomized controlled trial. The findings of that randomized controlled trial, FICTION, which stands for Fillings in Children's Teeth Indicated or Not, a controversial title alone, and the results of that trial that have been published in many different journals. So the Hall technique that I'm going to talk about is, for many of you who won't be aware of this, is a pediatric dentistry specific technique that we use to teach treat carious primary molars. And we do it by simply pushing over a little stainless steel crown that's been sized for the tooth, seal the carious lesion in without drilling it out and without preparing the tooth. So essentially, it's a very minimally interventive technique that doesn't require much from the child to cope with. And there are numerous studies that show that children don't mind having it done, and many that show that they prefer it to having local anaesthetic and a filling. And effectively what the crown does when it seals over the caries is isolate the tooth, isolate the carious lesion, and similarly to many stepwise caries removal, Fisher sealants over caries removal studies, and other studies that show minimal intervention techniques can stop caries progression simply by isolating the bacteria in the biofilm and stopping them from having access to nutrients. This is what the Hall technique does. So it effectively stops any nutrients getting into the biofilm, oxygen and whatnot, and it stops the biofilm from thriving. It presents it with a very unfavourable environment that it then has to last in. So we ran one randomized controlled trial many years ago now and published the first results in, I think it was 2007, that showed a number of different things. These are the 5-year results that I've got up on the screen. The main important point was that it showed that the Hall technique vastly outperformed the conventional restorations of dentists in the UK. And that, so the graph shows the failures, the major failures, which are pulpal outcomes and problems with abscesses and things, and the minor failures, which are problems with loss of restoration. But that finding was not a million miles away from the finding that we find commonly in the hands of practitioners trying to treat children in difficult circumstances where parents often don't want them treated. They've usually got many restorations that need carried out, and they're trying to minimize them. So we found that this technique of sealing in was not only preferred by children and parents, but seemed to work. There are now at least 5 randomized controlled trials that have gone on to show that as well. So there's our own one that was carried out in Scotland in the UK. There's one in Germany that was carried out with specialists in a hospital, one in Lithuania, one in Brazil, where the children were actually treated lying on desks in a classroom using the Hall technique, or ART, and one with someone who treated children with a Hall technique crown compared to a conventional crown restoration. And the findings of all of those studies were that the Hall technique had a success rate on even quite extensively carious teeth, as long as it hadn't gone near the pulp, of about 90% and over at 1 and 2 years, and even at 5 years in our own trial that we followed up. This was much higher than most of the studies in the hands of generalists and equivalent to the hands of specialists and equivalent to the conventional crowns. So our understanding that this sealing in technique could perform as well as conventional techniques in the hands of specialists, and certainly sometimes superior in the hands of generalists who weren't treating children as often as specialists, made us want to look further at what we could do with minimal intervention. So we were given a grant by the NIHR in the UK to look at the clinical and cost effectiveness of 3 strategies of managing caries in primary teeth. So this was now not just a very simple randomized control trial that compared one intervention with another intervention. This became a much more complex environment where we looked at the whole practice, the whole child, the whole mouth, and over a period of time. The idea was that we wanted to find a philosophy of treatment that could be carried out in the UK to a high standard in the hands of generalists, which is where most of children's dentistry is carried out. So the 3 arms were the biological one, which is in the middle here, which is Hall technique and various other things with best practice prevention. The standard conventional treatment of caries, where we remove the carious lesion as much as possible without causing a pulp exposure and provide a restoration, and simply providing best practice alone. You have to remember that each of these other 2 arms also had best practice in them as well. And we looked at mainly pain and infection rates related to dental caries. We also looked at the secondary outcomes of parent-reported child oral health-related quality of life, caries incidence in primary permanent teeth, the cost effectiveness over the period of the study, the 3 years, and the acceptability and associated experiences for the patient's appearance and dentists in a qualitative study. So this intervention is a bit like these interventions are a bit like a cake. We have 3 different flavors of interventions. And within that, we've got the standard parts of them. So every cake has, or virtually every cake has flour, butter, sugar, eggs and whatnot. But each of those cakes that you saw has got a number of different ingredients that makes them special. And this is how I try and describe the complex intervention that we undertook in the fiction trial for each arm. So there were key components that each arm had, which was prevention. But then there were these individual components, so fillings, which could be composite fillings in some cases, amalgam fillings in some cases, depending on what was recommended. In the biological arm, it was things like the Hall technique, Fisher sealing over caries, all of these biological approaches to managing decay by sealing it in. And finally, in the best practice prevention alone arm, we only did the prevention that we'd also done in the other 2. So toothbrushing instruction and help, diet advice and intervention, investigation, topical fluoride, all of these other things following the UK guidelines. So we've got the 3 arms, and this is just a diagram showing the patients coming in at the top, being randomized to the 3 different arms and then being followed up. But you have to remember that this was for the whole child and the child's whole mouth. So not just one tooth treated in a way, all of the teeth were. And this was for over 1,000 children across the UK, all in general practice settings with dentists. So the main outcome, as I said, was pain and infection. And what did we find? Well, after 3 years, we found that the percentage of pain and infection in children for the conventional arm was 42%, so conventional and best practice prevention. In the biological arm, 40% of the children had pain and infection. And in the prevention alone arm, it was 45%. That wasn't different. There was no statistical significant difference detected between there. There's no evidence of a statistically significant difference, I should say. Same with the episodes of dental pain and dental infection. We found that you can see from these 3 here, they all look exactly the same, or virtually the same. There's no detectable difference in the episodes of pain and infection. So most children had no incidence, but about half of them had 1 and 2 and 3 and so on. In one arm, they had slightly more, so some of them went on to have several episodes. No difference in child quality of life. Again, you can see that demonstrated visually here in the box plots. No difference in dental anxiety, which was very interesting for us because we'd anticipated that the children in the conventional arm might have more dental anxiety because they were having more invasive treatment, and the children in the prevention alone might have less, but we didn't find that at all. For the incidence of new caries experience in the primary dentition, again, there was no difference between the 3 arms. And the secondary outcome of incidence of new caries in the first permanent molars, again, no difference between the 3 arms. Exactly the same. A slight difference in numbers, but they were the same statistically. The cost effectiveness analysis, I'm not going to go through in great detail, but it showed essentially there wasn't a huge amount of difference because the slight gain in the in the prevention alone arm from the lower numbers of pain and infection were really offset by the numbers of children in that arm who also ended up having a general anaesthetic to manage their caries problem, which was slightly higher than the other 2 arms. So there was a bit of a balance that was struck there. But the conclusion, very briefly, from the cost effectiveness analysis, and you're very welcome to go and read the full paper, was that on average, it cost about 230 UK pounds to treat dental decay in primary teeth in these children over a period of 3 years. That on average, prevention alone was less costly, but slightly less effectively. And on the cost effectiveness analysis, that had an effect. Now, you have to remember that each of the children that came into this study had to have decay in order to actually be eligible. So they were a high caries risk population. And it tells us that in this high caries risk population in the UK, if we're willing to pay a threshold of £130 per episode, we would be best putting our investment into the biological approach, even though there weren't very many differences in other ways. And that is a very complex trial expressed to you in a very compact way. But what I'd like to explain is that this idea of carrying out randomized control trials in the environment within which we want to apply the technique is absolutely critical in terms of our usability of it. So we simply take the whole technique in one tooth and we have fantastic results. And there's no doubt it works. The pathophysiology is there and it makes complete sense. But when we begin to put the whole thing together into the environment, the randomized trials that we need for our dentists to carry out in practice, we've got very many other things that we need to consider in that. And this is what we tried to look at in fiction. But I think we really need to get good at looking at these complex intervention clinical trials for using in our environments. And I'd like to say thank you to my wonderful fiction team that took part in that study with me. Thank you very much indeed for your attention.
Thank you. I find that to be so innovative and creative, and I think will prove to be very influential. So thanks for sharing that with us. Also, thank you for getting my mind on cake and how that would be a really great treat to have just about now, no matter what time of day it is, where you are in the world. But brush your teeth when you're finished. And now our next presenter, Dr. Elizabeth Dimba, also from the School of Dental Sciences at the University of Nairobi, will be sharing some of her research. And this relates to how dentists in practice have been adapting to the COVID-19 pandemic.
Thank you very much for that introduction. Let me get my screen. Okay. I'm going to present data from a study that is entitled The Level of Preparedness Among Oral Healthcare Providers in Infection Control During the COVID-19 Pandemic in Kenya. The background of this study has been given by our Dean, Professor Regina Mutave, and the team that started this study is myself, Dr. Mutave, Professor Kimoli, and Dr. Kimathi. The purpose of this study was to provide background data that was needed for us to develop practice guidelines at the University of Nairobi, and also to serve in an advisory role to the professional bodies that govern the practice of oral healthcare workers in Kenya, and to provide advice also to the government when we were resuming studies for clinical practice at the School of Dental Sciences after a 2-month closure due to the COVID pandemic. So in introduction, the global response to COVID-19 pandemic requires amendments to infection prevention guidelines. Oral healthcare providers in Kenya are changing their clinical practice to minimize the risk of SARS-CoV-2 transmission in the clinic. And they are required to act as part of surveillance and referral teams for suspected COVID cases. The global pandemic has put a massive strain on the healthcare system, and it has caused a spike in demand for ICU and HDU services, with ventilator facilities required for critically ill patients. For example, in my country, Kenya, right now, there is a severe shortage of oxygen. There is a severe shortage of ICU and HDU beds, and so the preventive approach cannot be overemphasized. At the moment, we are in a 5-county lockdown. The highest incidence counties, including Nairobi, have been closed until the 29th of March, and our positivity rates are standing at 10% of all cases tested. So now, in this extraordinary situation, the entire system is required to adopt a preventive and multidisciplinary approach for the pandemic. Kenya needs approaches against COVID-19 that are appropriate for our national context, but we also need to exchange information, as we are doing in this symposium today, so that we can gain from the experiences in other countries and then adopt them to solve some of our problems. Oral healthcare workers require maximum protection due to their constant exposure to unmasked patients and bioaerosols. I think Dr. Mutave has mentioned that one of our postgraduates was actually infected by a patient earlier this year, and that is a situation that is very concerning. As we go through the results section, we are going to see some of the challenges that healthcare workers in Kenya, in both the public facilities and the private facilities, are facing in terms of access to PPEs. So this study was actually a situational analysis of infection control practices, which is going to facilitate evidence-based recommendations for safer practice in oral healthcare clinics. And it was conducted between April 2020 and March of this year. The general objective was to assess the level of preparedness amongst oral healthcare workers in Kenya for infection prevention and control during the COVID-19 pandemic. Specific objectives during this COVID-19 pandemic: to assess the knowledge of oral healthcare practitioners of infection prevention and control guidelines, to evaluate the attitude among oral healthcare practitioners towards infection prevention and control, to determine the infection control practices of oral healthcare providers in Kenya, and to describe the access of oral healthcare providers to protective equipment for infection control and prevention. And with this information, now we would be able to set standards and also guide government policy. This was a descriptive cross-sectional study, and the target population was randomly selected oral healthcare workers who are active in clinical practice in 6 urban centers in Kenya. The ERC approval number was P252/04/20. We had a questionnaire that collected data on the oral healthcare providers' socio-demographic characteristics, knowledge and awareness of the COVID-19 diagnostic criteria. It also assessed attitudes towards infection prevention and control, the current practices, and access to PPEs. So the preliminary results were very interesting, and there were some areas of concern that I'm going to highlight just now. The number of respondents was a reflection of the distribution of oral healthcare workers in Kenya. As you can see on the top bar, over 150 of our respondents were based within Nairobi, and that is a reflection of how dentists in our country clustered towards urban areas. Mombasa was the next, however, with less than 50 respondents. Nakuru, Eldoret, Thika, and Nyeri, all of them urban centers with a smaller number of participants. When we looked at the age and the gender of the respondents, we found that the dentists, the highest number of dentists was found in males who are over 30 years of age, who are over 70 in number, and then the males under 30 were 45. Female respondents over 30 were 56, and those under 30 were 59. So there was a broad distribution in the age groups. When we looked at whether or not our respondents had full access to personal protective equipment, now we started seeing issues that were a cause for concern that needed to be addressed as soon as possible. The respondents that said that they had the full access to personal protective equipment constantly when they were on duty were 51%, 137 in actual number. The ones who said that they had either partial or no access to PPE when on duty were 130 in number, and that is 49%. That is literally half of the dentists that are practicing in the sample population, reporting lack of access to personal protective equipment. We had a section of the questionnaire testing the knowledge of COVID-19 diagnostic criteria. The ones who were aware of altered taste sensation were 65. Those who reported a correlation between breathing difficulty and a high index of suspicion of COVID-19 were 23. Those ones who correlated an altered sense of smell or anosmia with COVID-19 were 76. Those who correlated muscle pain and a positive diagnosis of COVID-19, a suspicion of COVID-19, were 40. Those who correlated joint pains with suspicion for COVID-19 were 34. The symptom that was most related to COVID-19 was cough, and the majority, over 90% of our respondents correlated that with COVID-19. A runny nose, 73 of them correlated that with a suspicion for COVID-19. So the knowledge of the COVID-19 diagnostic criteria, which has been disseminated on public media, in newspapers, online by the Ministry of Health, appeared to be well available to our oral healthcare providers. And so that their knowledge levels were very encouraging in this study. When we looked at knowledge of infection prevention practices, there was widespread use of surgical masks, face shields, disposable gowns, N95 masks, latex gloves, and high volume suction. Fewer dentists, number 146, were comfortable with the use of rubber dam as a preventive measure for COVID-19. Few of them indicated that a cloth mask could be useful, which is also encouraging, because we do not recommend the use of cloth masks anymore in the clinic. And a large number of dentists were also using protective eyewear. Now, I would want to emphasize that the knowledge of the infection prevention practices did not have a high correlation with the access, because the access to PPE was more of an administrative issue, and the knowledge of infection prevention practices was more of a personal initiative that was taken by the oral healthcare providers to access whatever training that they could get, either online or in person or institutional, so that they could improve their practices. So in summary, what we observed on this study was that we had high, over 90% levels of awareness of the COVID-19 case definition. So in terms of screening, pre-treatment screening for COVID-19, the oral healthcare providers seemed to be well equipped to do it. The training that is available to them was by online seminars, especially with the Kenya Dental Association, in-person training, hospital continuing medical education, and public media. The barriers to non-availability of PPEs were mainly due to procurement procedures and stockouts. The procurement procedures may have been slow, and especially at the beginning of the pandemic, there was a point in time that even if you had money to purchase, there was no access to N95 masks. So there were terrible stockouts at the beginning of the pandemic. Right now, we are at the tail end of the third wave, and the delivery systems are much better. But at the beginning of the pandemic, a lot of our suppliers did not even stock some of the PPEs. So in this study, we saw that half of the oral healthcare providers had access to PPEs for COVID-19 prevention. And I think it was mentioned at the beginning of the symposium that we have lost 3 dentists to the pandemic, and that could be attributed to the lack of access of PPEs. This is a matter that needs to be taken very seriously. So as we process the data from this study, we are hoping that we are going to be able to share this information with the regulatory bodies and government to justify and lobby for access to PPEs. So the preventive measures to control COVID-19 are currently limited by access to appropriate equipment and consumables, at least according to our study. So in summary, the situation that we are having is that there's a good flow of information. There's a good exchange of information, and we're getting data from different centers as to what they are doing to control COVID-19. We are in the process of developing our own standards, but we have to also we have to also align our systems so that we have effective access to the consumables that we need. And this is the photograph that we are using to that we are using to end this presentation. These are is it called the good old days or the bad old days, where our dentist is busy, doing the cavity prep, and the aerosol is floating around. No cause for concern, but those days are gone because we are now in the era of SARS-CoV-2. Thank you for your attention.
Yeah, thank you very much, Dr. Dimba, for that look at how things are going on the ground among the dental practitioners across Kenya. We have one more presentation today, and this is from Dr. Kasoso Clint Mayamore Kunge, who comes from the Muhimbili University of Health and Allied Sciences in Tanzania. And I'll turn the floor over to you, Kasoso.
Thank you very much, man. I hope you can see my screen. As I have been introduced, my name is Kasoso Clint Mayamore Kunge from Muhimbili University of Health and Allied Sciences in Tanzania, Dar es Salaam. I will be presenting, this will be a very short presentation of a research conducted at the end of 2019 and beginning of 2020. I'm going to be diverting just a little bit from previous colleagues in the sense that my research presentation is not going to focus on COVID-19 exactly, but this is more of a oral health service utilization research, and it's a research on previous experiences and barriers to its tooth filling treatment in Tanzania. So it seems as if I'm having a problem with. Oh, right there. So the layout of my presentation, I will briefly touch on the oral health situation in Tanzania to give you context, and go into some details on the methodology of this particular research results, and some reflections emanating from the presented results. So to begin with, let me take you through the health facility organization in Tanzania, rather healthcare organization. So health services in Tanzania are organized in a pyramidal shape, and they are primarily centered at the regional level. So the region is like the administrative unit within the country. So the country has a total of 28 regions. And within each region, there are several districts, 5 to 10 districts on average. And therefore, you'd have a regional hospital. And then within that region, you'd have district hospitals. We'd have districts with district hospitals. And then within those districts, you'd have further subdivisions, wards, et cetera, whereby you'd have health centers, dispensaries, and so on and so forth. So this is how the health service is organized in Tanzania, and oral health services are organized along that same framework. Just to briefly place you in the context of oral health status or the oral health situation in Tanzania, Tanzania conducted its 5th National Oral Health Survey at the end of 2020, involving about 1,410 adults. So these are a nationally representative sample. And the findings are that from that particular health survey is that about 3/4 of the adults, that is 76.5 of them, had a dental caries experience. That is, they had a DMFT score of greater than 0. And of these that had a dental caries experience, about a half had missing teeth, extractions, conserved teeth about 1.7%, and more than 1/3, which is close to a half also, had caries teeth. Furthermore, in the oral health survey, about a half of them reported to have visited a clinic due to pain. But in this whole population, the proportion of respondents that went to the health facility or the oral health facility for dental checkup was a little bit less than 2%. And then let me just quickly take you through the oral health human resource for health status in Tanzania. So what you have here is a table, the latest figures that you have. On the far left, you'll see that we have, these are the categories of the health facilities. So we have the National Hospital, which is at the topmost. That is the MNH, standing for Muhimbili National Hospital. So my university is Muhimbili University, so it's located within the same compound. And then we have some specialized facilities. And then we have zonal hospitals. So we do have zonal hospitals whereby you'd have several regional hospitals being served by one major zonal hospital. We have 5 of them in Tanzania. And then we have RRHs. These are regional referral hospitals. Those are the regional hospitals. And then we have council hospitals. So this is at a much lower level when you go to the districts. You can see that by the year 2021, January, so this year, there are a total of 111 dental surgeons that have been employed in all these hospitals in their totality. You'll notice that we have specialists just to the left of them, a total of 41 employed within the Tanzanian health system. To the right of dental surgeons, you have ADO. So this is another cater, assistant dental officers, trained for 3 years. And then you have DTs. These are dental therapists trained for 1 year after their preliminary secondary education. And then you have DTL. So this is standing for dental technicians or dental technologists and lab technicians. So in total, the latest figure is in Tanzania that there's 618 oral health personnel. So mind you, this is everybody from the specialists to the DTLs. And there are a total of 5,764 facilities. And of those facilities, 240 of them, so about 3% of them have oral health services situated within those facilities. And therefore, the oral health professionals to the population ratio, there's 61 million people in Tanzania. So this is a 1 to 80,000 population. So after giving you that snapshot of the oral health situation in Tanzania, let me take you through the actual methodology of this research undertaking. So a cross-sectional study was conducted in 5 public dental facilities, which are located within regional hospitals in Tanzania. But these are regional hospitals which are located in regions with the zonal referral hospitals. The intention being that these hospitals are more likely to be very well equipped, to have a good patient flow, and therefore the likelihood that you'll encounter patients that have had a tooth filling. If you remember the National Oral Health Survey indicating that only about 1.7% of them had tooth fillings. So in these facilities, we're trying to maximize the likelihood that you'll encounter people that have had tooth fillings. So this involved adult dental outpatients between November 2019 to January 2020. Although, around January 2020, this is when the pandemic first wave started in Tanzania. So this, it moved all the way till around March 2020. And so patients were approached in the clinic during the waiting room, requested to participate and elicited consent. And once consented, they were consecutively enrolled. So this is a map of Tanzania showing the various regions that in different colors. And these red dots, you have over Mwanza, Kilimanjaro, Dar es Salaam, Dodoma, and there. So these were the sampled hospitals within the regions with these zonal referral hospitals. So 5 regional hospitals. And so data collection utilized a questionnaire, which was developed for this population. And a sample size was based on parameters of that. We expected 10% of the patients to have utilized tooth filling treatment, and they started the design effect of. So the questionnaire itself inquired on the socio-demographic characteristics of the patients, their oral care seeking behaviors, the previous experiences that they've had with the tooth filling services, as well as their perceived barriers to its utilization of tooth filling services. Now, onto the results. So a total of 736 patients participated. It was almost an equal proportion between all these 5 different centers, although participants from Dar es Salaam were slightly underrepresented, only 16.3% compared to the other regions. Slightly more females, that is 56.5, and most of them were of a relatively younger age. About three quarters of the participants reported to the dental clinic due to a toothache. And when we interviewed or asked them of their expectations, about half of them expected to receive a tooth extraction due to their problem. Less than a quarter expected any kind of restorative care, and the remainder really did not know. They had no idea what it is that they received. Now, when trying to assess, therefore, the previous negative experiences that these patients have had with fillings, about 26.3 of all those participants, that is, of the 736 participants, about 26.3% of them, about a quarter, reported that they have had a previous tooth filling. And so those patients were asked specific questions trying to elicit whether they have had any kind of negative experiences which were associated with that tooth filling which they had received previously. Now, at the bottom here, you can see that 61.7% of all those that have had a previous tooth filling reported to have had at least one negative tooth filling experience. And the experience which was noted most commonly was that the tooth filling place dislodged after a little while. So about half of those that had received a previous tooth filling had a dislodgement. And then perhaps concerningly, about 44% of those that have had a tooth filling also experienced a toothache subsequently after placement. And then this was followed by the fact that they had to extract this tooth which was filled. And then lastly, whether this tooth had fractured. When assessing the barriers or perceived barriers, cost and fear were perceived as significant barriers by about a third of the participants. But also, concerningly, about 43.1% perceived that they were uncertain with the treatment outcomes as the reason why they would not utilize tooth filling services. And I suppose in light of the previous results which I've just presented, it kind of makes logical sense. When trying to assess the associated socio-demographic factors, those with the lowest levels of education, low average monthly income levels, and those that utilize cash for payment of services, that is out-of-pocket payment as opposed to health insurance, had the lowest proportion that received restorative treatment. We also conducted some multivariate analyses and level of education, average monthly income, payment modality for health services, and patients' previous tooth filling experiences were associated with whether this patient would receive a tooth filling or not. So on to the reflections. I wouldn't call this a discussion, really, but more like reflections. Is that the awareness of tooth filling as a treatment modality was widespread. About 3/4 of them had heard of tooth fillings, and they have, they are aware of tooth filling services. However, the fact that about close to 2/3 of those that have received tooth fillings also reported previous negative experiences is concerning. And this implies that there is a high failure rate. So there's a likelihood that there's a very high failure rate of the provided tooth filling services within this particular setting. Also, it was realized that the clinic attendance was one of the most important determinants of whether a person received a tooth filling or not. Those respondents or patients that attended a specific clinic in Bear, so that is in the Southern Highland region, had a much higher rate of tooth fillings. And it was seen that issues such as flat rate of payment schemes, that is, there are no differences when people are paying out of pockets between either tooth extractions or tooth fillings, encouraged utilization of tooth fillings more. So to conclude this presentation is that increased emphasis on low cost, less technique sensitive restorative procedures, as we can see that there's high failure rates. So perhaps the simpler the procedure, the more likely that they'll be successful. All these may play a role in increasing utilization rates of restorative care in this setting, as well as increased emphasis on the role of preventive dentistry during service provision. With this very short presentation, thank you very much.
Thank you. That was wonderful. Thank you to all of our presenters. We're going to regroup for a panel session to take questions and answers from the audience. Anyone who'd like to put a question forward for our last three presenters, by all means, please use the Q&A function. That panel session will be moderated by Dr. Stuart Gansky, who's the Associate Dean for Research here at UCSF. And just before we get started on that, if you look to the chat, Roger will be posting a link to claim continuing education units. So for anyone who would like that, you can follow the link in the chat and request the units, and our team will send that to you in a reasonable amount of time. It's not instant, but we'll get it to you. And now I'll turn over. We'll have about 10, 15 minutes of a discussion.
Thank you, and thank you for three wonderful presentations, very interesting and informative. We do have some questions already queued up. So the first question is for Dr. Innis, and that is a question about the role of adherence to the assigned treatment regimen and how that might have impacted the outcomes and how you might have handled that in your analyses.
Thank you. That's a great question, especially as it was such a multi-component study. We set the threshold for adherence at being 80%. So within each of the arms, the dentists had, or dental therapists, had to comply with the treatment specific to that arm at 80% of the treatments that they carried out. So not just 80% of the appointments, but actually 80% of the activities across the appointments. So the threshold was quite high. Now, there is no figure to say that we should have picked 80% or not. And the reason we decided on that after a great deal of discussion was that this is generally the figure that's picked in most pharmaceutical studies, which was really the only other place that we could find any information on adherence figures. So we binarized the outcomes being adherence or not adherence based on that 80% figure. And what we found was that actually the vast majority of children hit that, the vast majority of cases hit that 80%. What we noticed was that there was swapping between the arms, and that was allowed within the study, that a parent could ask for the child to be moved to a different arm or have a different treatment if they wanted. And we found that occurred across all three arms, although it was at a very low level, but mostly the movement took place between the conventional towards the biological arm, or it actually took place in all directions, but also the non-restorative towards the biological, and non-restorative, so the simply prevention alone, towards the conventional arm. So some parents wanted less intervention in some cases for the child, and some wanted more, which was interesting. We knew the parents didn't particularly like the appearance of stainless steel crown in a few cases, so they opted to have a restorative treatment in those particular instances. But again, there were very, very low numbers. It's detailed in the paper, which I'll put a link to in the chat line in a minute. So yeah, adherence to we weren't concerned. Everybody did adhere as much as they could. I should also add that parents, dentists could carry out pulpotomies, pulpectomies, all those treatments that you would need to extractions and so on as necessary, but they were the same across all arms because the indications didn't change.
So as a clarifying follow-up, were the results that you presented, were those as randomized, or were those protocol compliant?
They were intention to treat, the ones that I presented to you today, but we also did per protocol analysis and we didn't find any difference. It's a great question.
Okay, thank you. The next question that we have is, excuse me one second, my mouse doesn't want to scroll up. Next question we have is for Dr. Dimba, and I think actually Dr. Mutabi partially answered this already online, which is of the dentists who were stricken with COVID and it resulted in their demise, were any of them transmissions that occurred in dental settings?
Thank you for the question, Dr. Gansky. There were 3 fatalities due to COVID-19 in the past 1 year. One of the doctors who passed away, unfortunately, was our colleague, Dr. Alumera, who was a periodontologist. The second one was a military dentist working in the Forces Memorial Hospital. And the third one was in private practice. We do not have the exact data concerning where they came in contact with a COVID positive patient, but we're working on the assumption that it could have happened in the dental clinic. Within the structure of the dental school, we have also had cases of among the undergraduates of a student who came in COVID positive after both the parents tested positive, and we had to work towards isolating her and the other colleagues that she used to commute with. They used to use the same car to come to and from the dental school, around about 5 of them. We had to isolate them. So we in terms of contact tracing and knowing where exactly these 3 dentists contacted the COVID, we do not have that accurate data, but we are working on the assumption that the COVID was transmitted within the dental clinic just to make our workplaces safer. Thank you.
Okay, thank you, Dr. Dimba, for clarifying that on those unfortunate circumstances for your colleagues. The next question that I have is for Dr. Nia Murie-Kunge. There's two questions actually, and they relate to dental therapists. And so the first question is, who trains the dental therapists? And the second is, what is the scope of practice for dental therapists and their practice locations?
Thank you very much, Dr. Gansky, for the questions. Who are dental therapists? Excellent question. Tanzania, as was presented, does not have a very robust or very well-developed oral health human resource. Muhimbili University of Health and Allied Sciences, MUHAS, which is where I'm working, is the only university in the entire country which trains doctors of dental surgery, DDS. So there are a couple of, about 3 colleges which are run by the Ministry of Health, which are training these dental therapists, which are low-level oral health personnel, primarily tasked with emergency care skills. So essentially, these are oral health personnel who are supposed to be working in health centers or in dispensaries or in low-level health facilities in order to try and address this great disparity in the availability of oral health services within the country by at least being able to minimize pain. Now, as regards to the scope of their work, that is this intended scope. However, due to the scarcity, the obvious scarcity, many times you have these dental therapists situated or located in some of the regional hospitals, in some of the district hospitals. In some of the district hospitals, in fact, they might be the only oral health personnel available. So many times, due to lack of better options, they end up carrying out activities and treatment far beyond their initially intended scope. It's unfortunate, but it happens. And perhaps it is done with good intentions to try and assist. But perhaps we need to look into this matter further and try to determine really what is going on in these facilities which are being run solely or headed by dental therapists. Thank you.
Okay, thank you. We have another question which doesn't appear in the Q&A, but is from one of the other panelists, and that's from Dr. Kapila, who's the other moderator for Dean Innis. And the question relates to whether your study can give any guidance on approaches perhaps for stratifying patients based on risk in order to determine if they should receive the traditional drill and fill versus a more preventive approach.
Thank you. It's a very interesting question. We didn't look at the level of risk of the patient within the study and do any analysis based on that, simply because every child that entered the study already had to have a caries lesion that had reached dentine. Now, for most of those children, that meant that they had a cavitated lesion in a primary molar, and for some of them, they had more than one. The study wasn't powered to look at the subgroups in that way. It really was just powered to look within the child. But it's an interesting point. And I think one of the things that we learned from doing this trial was that when you treat a whole child in a whole mouth and you impose a philosophy of treatment on the whole child as part of your trial, you have to remember that the initial expectations around failure rates relate to trials that were all done on single teeth. So we expected a failure rate of around about 20% for children who had prevention alone, because the studies that we looked at that had taken that approach, that was it. For studies with conventional approaches, the general failure rate for those extent of caries lesions were around about 10%. And for the whole technique, we had the data on a few trials, it showed about 3%. And what we found was that there was a multiplier, of course, because each child didn't just have one caries lesion, they were already at risk of caries, so they had multiple lesions. So the risk was duplicated in each child. So I don't think I could answer that hand on heart, except to say that every child was high risk by our definition when they entered the trial. I hope that helps to answer the question.
Yes, thank you. I think it's an important study, but it's also important that we try to make inference based on what the study actually showed. And like you said, everybody was moderate risk at least. So it's hard to know the impact of stratifying by risk. I have one additional question for you, and that is, what was the clinically meaningful difference that you used a priori in your study planning, since the groups were so similar in their results? I wondered what you had thought of as being a clinically meaningful difference in your planning.
So it was a non-inferiority trial, and we looked at previous data. So we used it. We tried to base all the baseline data that went into the sample size calculation on UK studies, because it was so specific to the type of environment with general practitioners and the NHS environment. So we used a study by Levine from 2002, where he hadn't treated any teeth and found about a 20% failure rate. The study by Tickle, who found about a 10% failure rate with conventional restorations, and that was actually replicated in some other studies, and a 3% failure rate in our own whole technique trial that had been run with general practitioners. And we used that to try and come up. So we expected an incidence of infection to be 20% versus 10% for the prevention alone versus conventional, and so forth and so on. We used a 2.5% significance level for each of the paired comparisons and a two-sided test. We then came up with the sample size calculation based on 25% loss to follow-up. But because the children were treated within practices, we used a 1.09 inflation factor to account for the similarities that might occur within the practice or within the dentist. So the clinically meaningful differences we expected were around that 10%, even up to 17% difference. And I think there was a number of reasons that are complex to do with that multiplier. We talked about the high risk and the fact that those populations were quite specific, that meant that our study really was quite more complex than we anticipated it when it came to the analysis. And of course, there was a big statistical analysis written up beforehand that we planned, but I think we hadn't anticipated all of the complexities with it that we would next time. Not that I would want to run it again.
Okay, thank you for those details. So the findings were well below the about 10% difference per group. So in terms of what you had expected to see based on the prior research.
Well, they were much higher. They were about 40% in all arms.
But the differences between the groups were less than the 10%, yes. And so now I know we're getting the message from Dr. Chaffee to wrap it up. I know this has been an excellent session, an excellent symposium, so I will hand it back to Dr. Chaffee. Thank you, everyone.
Yeah, a huge thank you for everybody involved who shared their wisdom and their findings and their insight today. Thank you to all our attendees for being here and hanging with us for the whole presentation, or for as much as you could. Thank you to everybody who's watching this as a recording asynchronously. All of our presenters, wonderful, wonderful job. Thank you for our moderators for handling all our question and answer sessions. You didn't hear or see much from our technical support staff, but you wouldn't have heard or seen anything had it not been for them. So huge thanks to Keiko, Nancy, and Roger, who made this event come together and made it happen. We had some support for putting this together, not only from our program in global oral health at the UCSF School of Dentistry, but also from the California Oral Health Technical Assistance Center, which is one of our initiatives here at the school. There is a question I see in terms of certificates of attendance. We don't have certificates just for attending, but if you would like to request a continuing education unit and that would serve your purposes, by all means, do so. In fact, Roger, if you could please put that link in the chat one more time, you can just click on that and claim your continuing education units, and that should suffice for attendance. Thank you, everybody. I'm going to hop in the car and drive up to a hospital and pick up my family, and hope you enjoyed it, and see you next time.